knowledge base isn't there, so you wind up buying a million things. So you're going to get hundreds of reps coming to you and say, oh, you need this, and you got to get this, and you got to get this, and you got to get this. So then finally you buy all that, and then you get started. And then after a few months, the frustration sits in. You don't have a plan. You're going in 15 different directions. Your patients are frustrated. You're frustrated. And usually what happens is in stage 2, in phase 2, a lot of doctors give up. And so what I wanted to do today, and I think the goal for today is you've got a lot of dry eye experience here, is to get you on a pathway and say, this is the way. And this is how we do it, and this is how we systemically treat these patients so that they get better, so that you can go to phase 3, where you become a superhero. And I'll tell you, when I first started cataract and LASIK surgery, this is going now 24 years, patients used to give me gifts. They used to send me cards. They used to, now none of that happens on the cataract and LASIK side. But on the dry eye side, you take care of somebody's dry eye, you've got a friend for life. They'll send you gifts, they'll praise you, they'll hug you, they'll do whatever, and they will consider you a superhero. So I want to go from 1, which is today. You guys are all great looking and happy and excited. Let's bypass 2 and let's get to 3. So where do you want me to point? Okay, there we go. So it's completely underdiagnosed. This is USA data, but basically half of the patients that have dry eye are not getting diagnosed. I've got 3 teenage daughters, so the old way of thinking that this is a disease of women over the age of 40, it's not that way anymore. 2 out of my 3 daughters have dry eye disease, MGD, and they're getting IPL. So what's the reason for it? Well, they don't eat anything that I eat. They think my diet is boring. They go, oh my God, all you eat is veggies and protein pancakes and the same thing every day. And they're on their phones all day. Their health and wellness attitude is out the door. They'll watch Netflix all day long and then start studying at 2 in the morning or something like that. So now we're seeing younger and younger patients. I've got 10-year-olds, 11-year-olds coming in for dry eye disease treatment. So it's underdiagnosed. I think we all know that. So the DED disconnect. So it's underdiagnosed. What happens a lot, I'm sure, Dr. Wolf, is this you when you see a patient, you kind of graze the eye and just go, okay, is this patient having LASIK? Okay, let's get LASIK. So in the US, we have WNL. Do you guys have that here in Australia? You just say, oh, within normal limits, but WNL stands for we never looked. And that happens. You know, if you're not into dry eye, you're not looking at the meibomian glands. You're not looking at the tear film. You don't look at the face. You're not asking them about diet. You're not doing any of these things. You're just going, oh, within normal limits. Ms. Smith, you got a cataract. We're gonna do cataract surgery. Sexy. Mr. Jones, you're -5. I can get rid of your glasses. Sexy. Well, let's, dry eye is sexy too. Now, one of the problems is that dry eye takes time. It's a specialty. It's a subspecialty. So we have all these subspecialties. We have retina, cornea, glaucoma, oculoplastics, uveitis, pediatrics. So to get into that subspecialty, what we tell people is, you got to take a year learning this one subspecialty. And then when patients are sent to you by other doctors who are quote-unquote generalists, you have the time to sit there with that patient and take your time and find out about all these things. Find out about their diet. Find out what they do for a living. Are they on their computer all day long? Are they staring at a screen? What meds are they taking? What meds are they taking that might be affecting their dry eye? So we have to treat this as a subspecialty. And then what I tell doctors is the first thing, if you're going to get into dry eye, is just slow down a little bit. So you're seeing patient, okay, you got a cataract, I know how to fix that, let's go. Your pressure's high, we're going to lower your pressure. Your eye pressure's high, we're going to lower your eye pressure. But dry eye doesn't work that way. You actually have to sit there, talk to the patient, get to know them a little bit to be able to treat them. And then when you're treating dry eye, you're going to be getting into a whole realm of things. You're an eye specialist, you're an immunologist, you're a dietitian, you're a pharmacist, you're a biotechnologist, you're an internist, you're a dermatologist, you're a psychologist, you're a neurologist, and you even get into cosmetology. You will be amazed how many times patients come to ask me, Dr. Toyos, what mascara should I use? I'm like, I never thought I'd be asked that question. Oh, well, actually what I've been using. No. So you have to get into that, and you have to learn that. And there's no quick fixes. That's the other thing. Patient has a cataract, you do cataract surgery, they're doing better. You know, you have to tell them this isn't a battle that's going to be won in a week. This is a war that we are going to systematically treat you to get you from point A to point B, and this doesn't happen in a week. And we'll get into the psychology of dry eye later in this talk. And if it's done incorrectly, it can be frustrating for a patient and a doctor. How many people here are doing dry eye right now? Okay. How many people here, when you see that dry eye patient for the first time, has already seen another doctor? Has seen two other doctors, 3, 4, 5. I have patients that come in and I've seen 5 doctors, and I've seen them in 5 different geographic places throughout the United States and outside the United States to try to get this taken care of. See, so it's frustrating to the patient that they can't find that person to take care of them, and it's frustrating as a doctor if you lose a patient because you're not taking care of them. So old school techniques, and this is one of the problems that we have to jump to new ways of treating dry eye patients, is that we're stuck in the old techniques and the old ways that we were taught on how to treat dry eye. I think I may have, in residency, got 5 minutes on dry eye. How about you, Dr. Wolf?
Oh, not that much.
Not even less than 5 minutes. But what was the treatment? It's in the books. You know, warm compresses, lid scrubs, artificial tears, goodbye. He mentioned it earlier. And if a patient doesn't talk about it, then you shouldn't talk about it. So if you see that their tear film stinks, they got meibomian gland dysfunction, and you're just like, okay, well, we're going to take care of this cataract. I can't tell you the number of patients that have had beautiful cataract or refractive surgery, and they see terrible. And the first thing they want to say is, well, the doctor did bad surgery. I go, no, the doctor did. It's like perfect surgery. The problem is that you have this condition, dry eye disease, that wasn't treated before you had the surgery. And this is the discussions that Dr. Wolf and I had in the beginning when I came to his clinic to talk to him about IPL, like how much better his surgery success is going to be using Optolite to treat these patients before surgery. Are you finding that?
Yeah.
Good, I need your help here. I'm
It's
not letting you fall asleep.
You're doing well, Rolando. It's all right. Go ahead.
And then it wasn't even seen as an inflammatory disease. I actually keep my one of my residency books in the office just to remind me how far we've come. That in the book, when dry eye was discussed, it wasn't even seen as an inflammatory disease. It was a problem seen of too little water. Your patient has too little water, and you're going to throw some artificial tears, lid scrubs. Well, so we got to start a new school of thought. So I always go back to Hippocrates. I like writing. I don't know if anybody is reading my books, but I like writing books. And I always, if it's medical, I always go to Hippocrates because his insights way back then still ring true today. Life is short, art is long, treating dry eye disease is an art. Opportunity is a fleeting experience. So when you see these patients, that'd be the only chance that you can tell them, hey, you're probably not thinking about this, but you have dry eye, and if you let this go, you're going to have some problems down the road. And sometimes I'm the first doctor that's ever said that to them. Well, I've been going to eye doctors for 20 years, and they never told me I had this problem. You know, this could be treacherous because you're learning a new way of doing things, and you're throwing out the old thoughts out of your head. And then judgment can be difficult until you get the experience. We were talking earlier about how once you start dry eye, the way you treat these patients over the course of a few years changes, right? We were just talking about that, how I can give this talk now because now I've been doing this for 20 years. And if you would have heard me give a lecture, 2 years ago, it would probably be different than the lecture today. And if you talked to me 5 years ago, different. And if you talked to me 6 months from now, this lecture will probably be different again. The good thing about traveling to Australia is like I was waking up at times when I shouldn't be awake, so I've actually tweaked this lecture 15 times, being up at like 2 in the morning with why am I awake? It's an inflammatory disease. If you remember that, just always say that in your head, this is inflammation, this is inflammation, this is an inflammatory disease. You can treat the patient so much better. Forget about everything else that you learn. Inflammation, this is inflammation. And if left alone, it'll get worse. I always use this as my example. If you went to your orthopedic surgeon, when you get older, you get an orthopedic surgeon, that's what I've learned. And you have arthritis in the knees or hip or whatever, you tell the orthopedic surgeon, I'm having, this problem. And they go, well, just put some artificial tears on and then come see me in a year or two. So that's essentially what you're telling these dry eye patients if you send them off with some artificial tears. Artificial tears is not even in our vocabulary when we're talking to these patients. If it's not an artificial tear that's doing something for me, like an Optimal or an oculocin that has some, what I think is anti-inflammatory effects, it's no use to me. Don't give me an artificial tear. And I don't want to give these patients an artificial tear. It's doing them a disservice. You're acting like an orthopedic surgeon that's not treating arthritis. Because we know what happens to patients with arthritis if you let it go. It will get worse and the joint will actually start to fuse and they won't be able to ambulate. Well, this is what you're telling these patients. And I do have patients that come to me and they're like this because of years and years of neglect of their dry eye. So the object of medical care should not be the disease, but the person who should be treated as a whole and not as an organ which the disorder appears. So you have to take a holistic approach. That's why I say you're going to be, once you sign on to be dry eye, you're signing on to a lot of different things. And I'm just going to go over them pretty quick. Is somebody watching my time? Because I forgot to start my stopwatch. Okay, so you got to be a dermatologist. So now, when I say slow down, patient walks in, you got to start looking at their face before you even look at them into the slit lamp. So the first thing we want to do as eye doctors is rush to the slit lamp. Pause, take a second, look at their face. It'll tell you exactly what's going on in their meibomian glands. If they have rosacea, they have meibomian gland dysfunction. If they have acne, they're going to have meibomian gland dysfunction. If they have age deterioration of their skin, believe me, they're going to have meibomian gland dysfunction. So don't rush into that slit lamp. That's the last. I pause. This is the patient, the distance between myself and the patient when I walk in the room, I make sure, not just because it's 6 feet and COVID and all of that, I still do that. I just want to get a good look at their face. I want to see their blinking and just having a conversation with me. What do their lids look like? Just normal conversation. You want to take all that in, so you become a dermatologist. And we know, how many times has this happened to you where you then finally go to the slit lamp, you look at their lid margin, you see all these telangiectasias, and you say, Ms. Jones, you have rosacea. And they say, I don't have rosacea. I see a dermatologist and he's never said I had rosacea. How many times does that happen? Good, I need your participation. I want you to, or else it's gonna be a long day. But it happens to me all the time. And then I have to show them a picture and I go, well, this is what rosacea is. Telangiectasias on the epidermis secreting inflammatory mediators that are breaking down your glands and breaking down your skin. So maybe at 26, where you have thick epidermis, your fibroblasts are still making collagen, you don't have to worry about seeing rosacea there. But since this is the thinnest skin in the face, I could see your telangiectasias. You do have rosacea. If you don't do something about it now, it's only going to get worse and worse. As that epidermis thins, then you're going to start to see the redness of your rosacea, right? DED and diet. This is going to be huge. This is like the next frontier. If you ask me, what's the next big thing? The next big thing is you learning your gut microbiota. If you look at any of the problems that patients that are having long COVID, it's been linked to poor microbiota. If you look at systemic diseases and why systemic diseases are worse in one patient than the other, it's because they have bad gut microbiota. So the big question I always get is, what, do you give these patients probiotics? No, I don't, because it's never worked. I've tried probiotics before, it doesn't work. You have to change their diet. And so that's a conversation. Really, you can't do that in 20 seconds. Like, you have to find out what they're eating, why their diet is the way it is a busy schedule, and then you're going to have to change it, and then what to change it to. So I actually, in my patients, I make them go straight vegan for 2 months. The shortest time that I've seen microbiota change is 6 weeks. I make them go vegan for 2 months, along with B12 shots, and that's a whole nother story. But old school thinking, doxycycline. Oh, you know, you have this patient in that first slide that I show you with the rosacea, put them on doxycycline. They have meibomian gland dysfunction, put them on doxycycline. The doxycycline is 30 to 40 years old. If you want a systemic anti-inflammatory, I got much better systemic anti-inflammatories than doxycycline. And doxycycline has been shown to destroy the bacteria that you need for a good, healthy microbiota and to decrease the inflammation. Remember I said, think inflammation, inflammation, inflammation. Did you know, and this, they found this with smoking, just basically a doctor saying to a patient, you have to stop smoking, will change 20% of the behavior of smokers, a doctor saying it. Now you've got plenty of studies showing that a doctor intervening or a professional intervening on a diet and saying, hey, your diet stinks, this is what you should be on, you'll be surprised, that little just conversation with them, how many people change their diets. So I have patients come in and they'll start with that. They'll go, I kind of got off the wagon a little bit, but I'm trying your diet, Dr. Toyos, but I'm feeling healthier. So not only will you change their dry eye, you'll change your gut microbiota, but you'll get them feeling healthier and you'll get them to save their life. If you want a good encyclopedia type book on diet, How Not to Die is a great book. Has, you know, just study after study after study going body parts. Don't try to read it as a book from page 1 to page 1,256. Just look things up. Okay, so this is a problem, what's this? If they're eating this, what is it going to do to their body? And again, a lot of it's linked to inflammation. You got to be an immunologist. I mean, I never thought I'd be talking interleukins and cytokines, and I thought I left that way back in medical school, but you're going to have to get into it. And I'll make it simple for you. Interleukin 17, you remember that, you remember half the battle. So T cells make T helper cells make interleukin 17. It's the most specific inflammatory cytokine for dry eye. If you can decrease interleukin 17, you're saving the patient from meibomian gland dysfunction and dry eye. If you look at one of the studies that we published in AJO, we showed that actually the M22, the luminous IPL system, before the Optolite, actually decreased the amount of interleukin 17, and I'll go over that in another talk. If you want to learn the inflammatory system and the adaptive versus innate, I call him the grandfather of dry eye. Dr. Sabota wrote a great paper. I bring it with me everywhere I go for every talk, so I can show you that paper. But I would print that paper and read it. It'll just open your mind to a lot of different things in terms of inflammatory cytokines in dry eye. We have done so many different studies on a whole bunch of different meds, and what was going on is in the US, they were taking systemic anti-inflammatory medicines and then making them into drops. So cyclosporin was successful. They thought, okay, well, let's try Humira. Let's try anacarna. Let's try, so all the way down the line, they tried every systemic medication that you think of, and they tried to make them a drop, and they all failed. The only ones that worked are the ones that actually decrease T cell production. So that's why we have cyclosporin, lifitegrast, Cequa. That's why these have passed the FDA and working. But believe me, all these other ones have been tried before. Now, if you can make a specific, and there is an oral medication that decreases the amount of systemic interleukin 17, if that can be made into a drop, then you have something. Somebody already has the patent, so if you're thinking about getting a patent, that's not me. And like I said before, Optilite actually decreases the amount of interleukin 17. So neurotropic keratitis. So this has been big here the last year or two. But if you're a LASIK surgeon, you've probably been dealing with neurotropic keratitis before. But now it's big topic. How are we going to actually get these patients' nerves back? So usually what happens in refractive surgery is, and even cataract surgery, is a patient comes in with dry eye, you do the surgery, they have a poor tear film, their nerves never regrow back the same way again, and now you have neurotropic keratitis, and now you're going to have to figure out a way to do that. So now you're a neurologist, because now you have to learn about small nerve cell disease. The confocal microscopy, it's getting there. It's still not like perfect in terms of showing you pictures of this nerve disease, but it's good enough to show us exactly what's happening in these patients, is that their nerves never regrew back the same way. And then it doesn't have to be even with surgery. Constant inflammation and a constant inflammatory tear will start to destroy those nerves over time. So you're going to have to find ways to rebuild that nerve. And you can do it, one, you go Optilite, get their meibomian gland dysfunction taken care of, get a better tear film. And over time, a better tear film, since that front surface is regenerating every 72 hours, sometimes those nerves can come back. But if it doesn't come back, you know, you have options. You know, there's platelet-rich plasma. Some people use autologous serum. I use PRP. There's purified nerve growth factor like Oxervate. Low-dose naltrexone, which I've been talking about for several years here, is an opioid antagonist that is a systemic anti-inflammatory. Instead of giving people Doxy, I give them low-dose naltrexone. I did a whole, there's a lecture that I gave in Japan on it. You can go LDN Toyos on YouTube and see all the information there. And then there's another systemic medication called Acthar, which is ACTH, but it's been shown to stimulate 5 receptors in the body to actually decrease inflammation. And it does, there's 3 receptors that the Acthar hits that actually decrease T cell formation. You're gonna have to be a little bit of a pharmacologist, right? Because there's all these different drugs now that you have to learn about. And you have to learn the mechanism of action. I mentioned Optimal and oculocin. So you're gonna have to research these things and kind of learn mechanisms of action. It's not as simple as just taking a cataract, putting a new lens in, or lifting a flap and doing some laser. So there's some work that you have to do. Supplements, you're gonna have to learn about what B12 stimulating just about everything, but in terms of what we're talking about, dry eye, stimulating lipids. So what's happening is the new diets that we're creating and the food that we're creating is very B12 deficient. Also, as you get older, the intrinsic factor is not being produced, so you're not absorbing as much of B12 as you are. So essentially, anybody over 45, 20% of the world population has a B12 deficiency. Then NAD, you know, we're talking about Optilite providing light to stimulate the mitochondria to work better. Well, what does the mitochondria need? What does the powerhouse of our cells need? They need NAD. As you get older, the amount of NAD in your body starts to decrease. So if you ask me, 2 supplements that I love putting my patients on is NAD to stimulate the mitochondria to work better, and then astragalus. If you don't know about this, is Nobel Prize-winning research showing that this Chinese herb will increase the telomere on your DNA. The longer your telomere, the longer that you will live. The telomere is like the buffer zone of the DNA when it's going through transcription, so you're not injuring DNA as you're going through this. So these are 2 supplements I like putting patients on. So you're a pharmacologist now. You're a cosmetologist, like I said before. Patients ask me, what mascara to wear? What makeup do you use? And so I've had to learn about that. But let's just talk about false eyelashes. So if you don't know about this work has already been done. Some engineers said, you know, why do we need eyelashes? What do they do? Well, it turns out that a certain length of eyelash will keep a tear on your eye longer. If your eyelash gets a little bit bigger, then the tear will evaporate quicker. And if you have no eyelashes, like a lot of these dry eye patients over time start to lose their eyelashes, that's a problem as well. But the biggest problem is long eyelashes. So this is actually a patient that came in to see me with these false eyelashes, and she was wondering, why do I have dry eye? Why do I have blepharitis? Why are my eyes red? And I'm like, well, look at these things. I mean, it's almost like the Muppets, like where you see these things, like what is this? And lo and behold, she took this off, her MGD got better, we did some treatments with Optolite, and now she's happy as a clam. So you're gonna, guys, you're gonna have to learn, about makeup. You're gonna have to learn about these things if you really want to treat your patients holistically. Psychology. This is huge. There's a psychological component to dry. How many people agree with me there's a psychological component to dry eyes? Right? Chronic pain, so I don't even, you can step in a minefield talking about this, right? If you say, oh, there's a psychological component. If you talk to the patient about it, that could be a little bit of a minefield because they think, oh, you're like that other doctor saying that I'm crazy. No. Step back. Here's what I'm saying. Chronic pain, my mother was a sufferer from chronic pain, will change your personality. She was the happiest person I've ever met in my whole entire life. Chronic pain completely changed her personality. That is what's going on with these patients. With chronic pain, with chronic disease, it starts to increase their depression, starts to decrease their mood. I'm going to bring Svoboda up again. He had this study. If you haven't heard about it, it's one of the greatest talks I've ever heard on dry eye. He has dry eye mice. One group of dry eye mice he put isolated with no toys and no friends. The other group he put with toys and a bunch of friends. And the mice with friends and toys, their dry eye got better. Don't ask me how he measured their dry eye. I don't know anything about that. That's Svoboda's thing. So that's his lab, but great study. The other thing is, and I learned this with TLC, and I'm sure Dr. Wolf knows this with LASIK patients. If you have a LASIK patient that has some type of problem, you don't dump that patient, meaning that you ignore the problem, you don't talk to them, whatever. TLC is a big LASIK group in the United States, and one of the things that they found is where things go haywire between a doctor-patient relationship and LASIK is when the doctor withdraws, where they go, oh, Mrs. Jones calling again? No, I don't want to take that call. And then that's when things deteriorate, the patient leaves, and they go somewhere else. So I get made fun of for giving my phone to my patients and answering texts from them is the best thing, one of the best things that I've ever done. The text takes 2 seconds, it keeps that tie, and it keeps them from going down that depressive cycle. Same thing I learned with my mom. Just somebody talking about it, just somebody having a sounding board for their chronic disease syndrome will help. And I always tell patients the happiness, get happy. Don't stay in this cycle, because what you'll do is you'll you'll spin out of control. And there's dry eye patients that have actually committed suicide. The placebo versus the nocebo effect. So you're talking about social media. Social media is the greatest thing. If it wasn't for social media, IPL would have never gone off the ground because doctors didn't believe me. All the doctors, I was a heretic. What are you talking about? First of all, we don't want to talk about dry eye. And second of all, what the heck are you talking about? I was that crazy doctor talking about light and dry eye. I was the only dry eye, it'd be like all this stuff, all the sexy stuff, and then dry eye, and then I'd be on the last day of Ascaris. It'd be Tuesday afternoon, 3 o'clock, or Escaris, or any of the other meetings, or Oscaris. But they've invited me to the meeting to talk about dry eye, so kudos to them. But social media has a dark side. The dark side is these patients are developing their own networks, right? They're discussing things with each other. And what you're going to find is if you have a very vocal patient, they will say something like, oh yeah, cow manure, rubbing it on my lids completely cured my dry eye. And then you'll have patients texting me, hey, should I put cow manure because it helped this one woman completely cure their dry eye? And then they'll get followers, and they'll get 20 or 30 followers, and I'm making that up. Nobody's come to me with that, but pretty close. So should I do this? So there's the placebo effect, and then they'll come to me and they go, I did it, and actually it worked. It's the best thing ever. And they'll talk about it for 6 weeks, and then it will die, right? Because it has no scientific basis. It doesn't really work. But the placebo effect has worked with them. But there's the other side of placebo. There's a nocebo effect where if, like say somebody goes, oh, I did this treatment, it didn't work, this treatment sucks, don't do it. And then patients will be, even if patients get the treatment, they already have it in their mind that this treatment sucks, it doesn't work. So you, as a psychologist, you're going to have to work with both of those sides, the placebo and the nocebo effect, because what you have to tell the patients is this is not one size fits all. Basically, this is your treatment, this is what we're going to do. We're going to find the best path for you to control your dry eye disease. So don't listen to this person on that treatment or this treatment or that treatment. This is very specific for you. So don't let that play into your mind because it does work. All right, and guess what? That's my last slide. Biotechnology, we're going to be talking about it all day, but you really have to embrace biotechnology and all the research that's going on. And then you'll become a DED super doctor. Okay, so hopefully that'll set us up for the rest of the day.
Thanks, Rolando. That was fabulous.